All right, so basically the last specialty that we're going to cover this year is psychiatry. And so this is sort of a somewhat different approach in medicine to kind of understand human health and wellness. And it also allows us to look at mental disorders, which unfortunately are fairly common in today's population. There are a couple reasons why I like to include psychiatry in our biomedical science course. One is that most medical school programs do require a psychiatry rotation during clinical years, so all medical students, even if they're planning to go into something different like surgery, do have to do a little bit of work in psychiatry. The other one is that sort of in today's academic landscape, psychology is really popular. And while there are such a thing as clinical psychologists, psychiatry is sort of the medical arm or the medical version of this. So if you're someone who really likes psychology or takes the psychology course at Mercy and enjoys it, but you also think, hey, I'd really like to be a medical doctor, then psychiatry might be a route for you because it is an area of medicine which also fits our course well for this reason, that doesn't require a lot of physical examination, right? It requires a lot more conversation, a lot more of those communication skills, and a lot of the diagnoses don't require or don't even have, clinical tests that you can do, but it comes down more to your expertise as a doctor. And so that's why I'm hoping to give you guys the opportunity to ask some questions of one of my friends who is a psychiatrist, to just get an idea of kind of how she goes about her day and how she goes about diagnosing people. Now the question is, what is psychiatry? And I assume most of you kind of know, but it's the field of medicine where you gain expertise in the cognitive brain. So realize that's not the physiological brain, right? Neurology would sort of be in charge of that side of things. The cognitive brain means how people think, right? And so a psychiatrist specializes in diagnosing and then recommending treatment for various mental disorders. What they say is that psychiatry is a very multi-dimensional or uses a very multi-dimensional approach. And so when you look at someone and you're attempting to evaluate a potential mental disorder, you're not only considering the biological factors, which are sort of the main factors in most medicine, but also the psychological and social factors. So how is this person behaving, and how does this person see the world around them? Psychiatry can be both inpatient and outpatient. So, you watch TV and you see those things, right? You can have outpatient psychiatry where you go in and the people always lay on a couch in an office or whatever and talk, or you have people who are institutionalized. Now, treatment in psychiatry can be a little bit complicated, and it's also usually a mixture of chemistry, right? So medication, but also psychotherapy, right? So therapeutic sessions where you do speak with an expert in this field. And then a lot of times psychiatrists will further specialize in subsets, right? So you might get psychiatrists who specialize in working with children, or psychiatrists who specialize in working with older people, or you might get psychiatrists who specialize in particular diagnoses. So for instance, again, right now my friend Dana is a psychiatrist, and she's kind of floated through several different sort of specialties, but right now she's working in addiction psychology. So she's helping people in particular who have addictive disorders. And so we'll kind of take a look at all these different types of disorders, and you can see what kind of things are out there that these doctors might be working with. Now, what we say then is that a psychiatrist is an expert at performing a cognitive evaluation. So cognitive evaluation, right, is an evaluation of someone's mindset, how well their brain, so to speak, is working. And it doesn't involve as much physical manipulation, right? This is not like checking someone's reflexes or getting their heart rate or listening to their heart or their lungs. This is very much a piece of medicine that involves excellent communication skills, right? So if you have a patient that's over 65 years old, or a patient of any age that seems disoriented, it's often recommended that you do a formal cognitive evaluation with every physical exam. Now, what oftentimes takes place is what's referred to more as a mini mental status exam. So, with a full physical exam performed on someone, the doctor would usually ask a few questions just to kind of verify in a basic sense that people are aware of their surroundings in a cognitive sense. But just a list here, and we won't go through this and spend much time on it, but this is what a formal cognitive evaluation would include. All right, orientation. Do you know what time it is? Do you know who you are? Do you know where you are? Right? Attention and concentration. Can you count? Can you count backwards? Can you spell? Can you spell backwards? Memory. Memories can be remote, like when's your birthday? When's your wedding anniversary? Something like that. Memory can be more short-term, right? Recent memory. What'd you have for breakfast this morning? Versus recall. I ask you to remember something, and I ask you a few minutes from now. So like in this video, maybe right now I say, okay, remember these 3 items: teddy bear, pencil, and stopwatch, right? And then I ask you more questions, and then I come back later and I say, hey, could you tell me what those 3 items were that I asked you to remember earlier, right? Intelligence, right? You can do different tests of people's intelligence, or what we think of like IQ, right? Abstract reasoning. So you ask somebody, hey, can you explain this proverb to me? Like I put on here, don't judge a book by its cover, or people in glass houses shouldn't throw stones. If people can't reason abstractly, that's saying something. So if I say, don't judge a book by its cover, what's that mean? And they simply just say, well, you never know how good a book is by like the artwork on the front of it. That might be a bad sign, right? Other than them saying, well, when you get to know people, you never want to put too much in that first time you meet them, that sort of idea. Similarities and differences, right? How are an apple and an orange alike, or how do they differ? Judgment. What should you do if, right? If people are having an issue, they might have judgment pattern that you would not expect, right? They might suggest criminal activity or something like that when most people wouldn't. And then sensory perception coordination, you're going to ask people to draw things or stuff like that, which can be a struggle if someone is suffering from some sort of cognitive defect. Now, I just wanted to point this out. Those of you who are in psych have probably heard of this before, the DSM. DSM stands for Diagnostic and Statistical Manual of Mental Disorders. More than almost any other area of science, psychiatry has its guidebook, and that's what the DSM is. Basically, the DSM is a really thick book which highlights what the mental disorders are and how do you diagnose them. We've got a couple copies of this, I think, in the psychology classroom at Mercy. But DSM, the current volume is DSM-5, or the current edition, which has been out for a while now. I'd imagine the DSM-6 is probably on its way soon. But basically, within the DSM, you've got like this hierarchical setup of disorders, right? So that certain disorders are higher order than others, meaning like more severe, right? So what you do is you diagnose a patient with the highest order condition that you believe they would have. And that will oftentimes kind of encompass those things that are lower down on the criteria, right? So for example, like I put on here, if a patient has a higher order condition like dementia that you might see in an older person, then you wouldn't give them something lower order. Memory disorder is a simpler diagnosis that just involves particular areas of memory that is really part of dementia. So that's kind of how it works. It's sort of like a little hierarchy where you diagnose whatever they would have that's highest up on that hierarchy. Now, I stole this from Ms. Shane Backler in psychology. It might have come from the textbook they use or something, but a lot of times what they say you can remember is that psychological disorders involve MUDA, M-U-D-A. What that means is that psychological disorders are these 4 things, right? Maladaptive, which means sort of an exaggeration of what is normal in someone's behavior. And that exaggeration of that behavior is destructive, whether it's destructive to the person or it's destructive to those around them. The U stands for unjustifiable, right? Behavior without a rational or logical basis for why they're doing that. The D stands for disturbing, meaning it's a behavior that's troublesome to other people. And I'm sure hopefully you don't have really good examples of this, but I'm sure that you've been in public before and you see somebody who is behaving in a somewhat disturbing way. This might be something that makes you slightly uncomfortable, right? And then, or really uncomfortable. And then the A stands for atypical. And so atypical meaning that behavior is so different from others' behavior that it violates a norm. And so that takes us into a whole other area of psychology to talk about what a norm really is. But just for our quick purposes here, a norm would be, something that's established as acceptable in your culture. And norms can differ depending on your culture, right? There are certainly norms in, say, like Asian culture that are not norms in American culture, and there's all kinds of examples like that out there. If you've never seen Kathy Bates in the Stephen King film Misery, you should check it out. She's a very, very good actress. And if you're like me and you like to read the book Misery by Stephen King, which is way better than the movie. Now, what we're going to do with the rest of our notes here is a little survey of mental disorders. So sort of like with infectious disease, where we went through some of the infectious diseases and talked about the symptoms they cause and what they were, we're going to do that with some mental disorders as well. And kind of pick our way through parts of the DSM. I've left some things out for sure, based for time or for how common things are or whatever, or maybe things that you have heard of, I've included, versus probably some things you've never heard of. But we're going to run through all these different ones. But I also want to point out too, before we got too deep into that a lot of times, when people have a mental health assessment and it comes back as abnormal, a lot of times what a doctor might diagnose is that someone has a condition that's due to another medical condition, meaning that the mental symptoms or the psychological symptoms that are being observed are not actually a mental disorder, but they're symptoms coming from something else. So for instance, if someone was suffering from brain cancer, right, a tumor in the brain, it could certainly cause some atypical behavior, right? And if we saw that, we might initially want to say, hey, this person has a mental disorder, but maybe it's not that, right? Maybe it's because of the tumor is, putting pressure on a certain part of the brain and it's causing them to act in a strange way. Infections can do this too. Really widespread systemic infections can cause people to behave in odd ways. And so in that case, it wouldn't really be a mental disorder. It would be that we need to treat the infection and then those mental signs will go away. Now, before we go any further, I want to point out a really, really important point here that I believe any psychologist or psychiatrist would stress, and that is that today we understand mental disorders as physical disorders, right, that have really anatomic and biochemical causes. Previously, even in the medical community, a lot of times mental disorders were, just thinking that people are kind of messed up, right? That guy is crazy. That person is really just a big sissy or whatever it might be, right? Or this person suffers from depression. Well, they're just weak, right? And that is so far from our current understanding of mental disorders in medicine. Mental disorders are the result of an anatomical or a biochemical issue, right? Meaning that we can treat that, right? We can change the biochemistry of the body with medication. We can change an anatomical issue with something like surgery or whatever. And so, these are very real diseases, right? And again, there was a stigma. There still is a bit of a stigma, I think, with mental disorder. People don't want to talk about the fact that they have issues with depression or they have issues with anxiety. And what you want to keep in mind, right, is that if somebody's not embarrassed to say they have a headache, then they shouldn't be embarrassed to say that they have a mental disorder. Right? Now, unfortunately, we can't, impress that upon everyone, and so the stigma continues. But I want you to keep that in mind. And so if you yourself have struggled with anxiety before, or if someone you know or someone you love has had some issues with mental disorder or mental health, try not to think of that as something to be ashamed of or to be embarrassed by. It is just as real as someone who has diabetes. So keep that in mind, and I always try to be sensitive to that as we talk through this stuff in class. And ultimately, we're not going to go into a deep discussion of anatomy and physiology here, but it has to do with neurotransmitters. So you have all these different chemicals. I listed a few down here. in your body that allow your nervous system to work. And if these chemicals become out of balance in some way, they can cause people's behavior to change, and we can end up with mental disorder. So we're going to start first with the schizophrenia spectrum. That's what it's called, or psychotic disorders. All right, so psychosis is a pretty generalized term, but psychosis means behavior marked by a break from reality. So someone is behaving in such a way that it's clear they do not have a good, firm foundation in what is real and what is not. Right? Now, there are a lot of different conditions that can lead to psychosis. And so that's a big rabbit hole to fall into. But schizophrenia is kind of the primary brain disorder that leads to psychosis. As I mentioned earlier, a lot of mental disorders, there are not tests. So there are no tests for schizophrenia. Schizophrenia is oftentimes diagnosed in patients because of sort of the array of symptoms that they show. And like you notice at the bottom here, you never immediately diagnose schizophrenia. Symptoms in a patient have to persist for over 6 months before someone would think that the psychosis they're observing is the result of schizophrenia. But schizophrenia can involve delusions. It can include hallucinations. People oftentimes hear voices talking to them, but they also might have visual hallucinations where they see things. Disorganized thinking, speech, or behavior, meaning that everything they're doing just doesn't seem to fit together, right? Paranoia is common in schizophrenia. They think people are out to get them. Fear and anger usually as a result of that paranoia. Also, you're going to see negative symptoms in schizophrenics. So these people might not behave in what we would think of as a quote-unquote crazy way. They might actually be very subdued, right? They might have a flat affect, which means they don't show very much emotion at all in their facial expression. They might not say much, or they might speak in a really monotone way. And they might not be motivated to really get up and do anything. Now, if you look on Schoology, I've included a link to a really old video. It's going to feel very dated, but it's actually the video, and we watched a longer version, that we watched in medical school to kind of introduce us to schizophrenia. And so even though it is old, I think it's from the 70s or something, it's actually a pretty good video about this patient named Gerald, who had, at the time, very typical schizophrenia. I think the video is 8 or 9 minutes long. I don't think that you really need to watch that, but maybe you watch the first 2 to 3 of what schizophrenia can look like in a patient. Now, nobody really knows what causes schizophrenia. Some have suggested that it involves genetics. Others that it actually comes after viral infections that are severe. Others think it might be an autoimmune disease where the body's immune system is attacking the brain. They're not real sure what it is. They try to study schizophrenia with twin studies. And what they found is that sometimes it's not strictly genetic because one twin can have schizophrenia while another does not. But this is a cool comparison of the brains that people with schizophrenia do have an anatomical brain issue, right? They have a lack of electrical activity in their brain. They have a smaller cortex, meaning kind of this area out here is not as full, and they have enlarged ventricles, which I think is the most obvious thing on these pictures. When it comes to treating schizophrenia, it's sort of a toss-up from patient to patient. They call it the rule of thirds in textbooks, and that's that roughly 1/3 of patients will respond well to medicinal treatment, drugs. 1/3 of patients will somewhat respond, but behaviorally won't take their medication. And then 1/3 of patients don't respond to medication even if they take it as they're supposed to. And this is kind of true of all psychotic disorders. I put on here arguably the most successful antipsychotic medicine is called clozapine. The problem with clozapine is that it does cause a pretty marked decrease in white blood cells, and so it does sort of decrease the efficiency of the immune system to give this medicine, which at times can be kind of dangerous for people. All right, second thing is mood disorders. I think mood disorders are really important to talk about because these are ones that are more common and may have affected you or a loved one before. The first one we'll bring up is major depression, right? Now, major depression is actually sort of a group of disorders of different things. Melancholia is a more specific diagnosis here. You guys have probably heard of seasonal affective disorder before, where people have struggles with depression when it's winter. But major depression is really common. Now, before we go too deeply into that, I want to make sure that I'm clear and point out that times of depression are very, very normal, right? I would go so far as to say that all of us should have small times of depressed mood throughout our lives. And that's perfectly normal, especially when there's an obvious stimulus, right? You have a breakup with a boyfriend or a divorce from a spouse. You have a loved one who passes away. You lose a job. You don't get into a program that you've applied to. These are times where you can certainly experience some depression. I can tell you myself, when I was in medical school and coming down to the end of when I left medical school, I was certainly dealing with some depression because I wasn't happy what I was doing. Then I left medical school, which was my choice, and for a period of time there, I didn't really know what I was going to do. Right? And I also, dealt with some depression at that point too. Now, I would never say that I was at the kind of diagnosable point, and I never was treated for it. But that again is normal depending on what's going on in your life. Now, you would formally diagnose major depression if someone's depressed mood led to a functional impairment, right? So it starts to really affect their life. Unfortunately for you guys, major depression is about 2 times as common in females as it is in males. But all types of depression that we see are cyclic. So people have down times, and then they have times that aren't quite as bad. And so, I do urge you, if you do feel like you are depressed, to talk to someone. Again, it could be perfectly normal, or it could be a situation where it's starting to be a bigger issue for you. And if you feel a little bit better at a certain time, don't necessarily think, oh, now I'm fine, because that might not necessarily be the case. The way we treat major depression is sometimes with psychotherapy, so talking to people, but also with antidepressant medications. And so there's a couple big groups, you don't have to know these, but MAO inhibitors, or what are called the SSRIs. You've probably heard of SSRIs before, Prozac and Zoloft. These are all medicines that will help to improve people's mood. Now, if you're curious about mood disorders, right, what we look for, certainly the first thing is just a depressed mood. Someone feels sad, right, feeling down. We clinically would call this dysphoria, right? Anhedonia is another clinical term of something that we see, which is that people have a lack of interest or a lack of enjoyment in activities that they usually liked or they usually enjoyed. So if, you see someone who seems really down and they also tell you that, I used to really like to paint or something like that, but now I just don't feel like doing that ever, that could be a sign of a mood disorder. Loss of appetite, that was a big one for me when I was struggling with this. Trouble sleeping, another big one for me. Might just feel lazy, right? Decreased energy, feeling worthless or feeling guilty for something that maybe they shouldn't feel guilty about. Trouble concentrating, shows up a lot at school or work, or just thoughts or preoccupation with death, right? Which obviously we want to make sure we take seriously. But again, super biochemical, right? This is something that is not just, again, somebody being, sad or being lazy or whatever. This is something that you could potentially treat with medicine. And then I also threw this in as kind of a separate note here that a lot of times depression is associated with stroke. So if someone has a stroke, they may suffer from major depression afterwards. If somebody has a really minor stroke, they actually might not even know that happened, and it might trigger some depressive symptoms. Second thing to bring up in mood disorders is bipolar disorder. There are several subtypes of bipolar disorder, but I like to bring this one up because I feel like bipolar disorder kind of has a common misconception that goes with it, and people tend to use this term like, oh, my friend's bipolar, when they really shouldn't, right? So bipolar disorder means that a patient has these very kind of distinct time periods of abnormal and elevated mood, where they might be really elevated and irritable, that sort of fluctuate with times of being more depressed, right? And this elevated or irritable mood we call mania or manic episodes, and then you have depressed episodes as well. And so bipolar, meaning two poles, is what we're talking about here. Is there's these two major swings. Manic episodes or mania usually involves a lot of inflated self-esteem, or someone what we call grandiosity, right? Somebody thinking that they're a big deal. Might not feel like they need to sleep because they're really hyper. Also goes with that, they might be more talkative than normal. They might not be able to concentrate. They might be distractible. We call it flight of ideas. They can't concentrate just because they're all over the place, right? And then manic episodes also might include excessive involvement in activities that the medical way to put this is that have high potential for painful consequences. So this might mean somebody who goes on a ridiculous shopping spree that they can't afford. Somebody who has an affair outside of their marriage that obviously is going to wreck their marriage. Somebody that goes out and gambles a whole lot at a casino or at a horse track or something like that, and then subsequently loses a ton of money. This can be part of mania. And then that manic episode will distinctly just stop and they'll be depressed, right? And the manic episode could come back or be triggered just kind of on a dime, just out of nowhere. So this abrupt swing between mania and depression. Now here's the common misconception though. Right? Some people seem to believe that bipolar disorder is like a minute-to-minute thing. Like this morning, your friend is going to be manic, and this afternoon she's going to be depressed, and then this evening she's going to be manic again. That's not common, right? Typically, a manic period lasts for days or even weeks, and a depressive period lasts for days or even weeks. And so some people might just really suffer from depression, and think or get the idea that they're bipolar, but they probably, I don't want to say they probably aren't, but it's not likely that they would swing rapidly back and forth a lot. Usually, bipolar disorder is diagnosed when you're in your 20s, so a little bit older than you guys, and it does appear to have genetic factors. So families where you see bipolar disorder in the parents or any kind of mood disorder in the parents, it becomes a little bit more common in their children. All right, our third group are the anxiety disorders. And again, we want to stress right off the bat here that anxiety is normal, right? We expect people to experience anxiety and nervousness, and it is an extremely normal and transient response to stressful situations. All of us have stress, and everyone's stress is a little bit different. But everyone's stressors are real, right? So for instance, me as a guy in my mid-30s with a family, I've got different stressors than you guys have as high school students. But those stressors give us anxiety. Now, anxiety in a lot of cases can be good for you, right? Anxiety can be a response that causes you to more actively approach your stress and perform well, right? There's a ton of athletes who have said before, they get so anxious before a game or whatever, and it actually kind of puts them on their toes and effectively makes them better. I personally believe when I was in school that a little bit of test anxiety was a good thing because it got me to study ahead of time and it kept me very alert during a test. But you guys know that anxiety can become too much, right? Anxiety on a test can be debilitating. Anxiety before some sort of performance can be debilitating. And we consider anxiety pathologic if it falls under a couple different things, right? If it has no clear trigger, so we can't figure out why someone is anxious. It is particularly intense, right? It is persistent and won't go away, right? Or it leads to disabling behavior. maybe such as withdrawal from activities and things like that. But at the end of the day, ultimately, anxiety is a problem that interferes with your daily life, right? If anxiety makes it hard for you to function and perform your daily activities, then anxiety is something that we need to address from a medical perspective. So generalized anxiety disorder is a very, very common disorder that we see. It can lead to physical symptoms, right? It can certainly lead to affective symptoms or mood symptoms, and it can cause changes in behavior. In terms of like physical symptoms, right? Anxiety can cause, a racing heart. It can cause you to sweat. It can cause stomach problems. It can cause you to feel like you're going to pass out, right? Anxiety moods can range big time. You can be on edge and very irritable. You might be terrified, right? You might feel constantly worried or obsessed over some particular thing. And then, like we said here, disabling behavior. Maybe you start to avoid activities, or maybe you take on compulsive behaviors, like you feel like you have to do a certain something because your anxiety is so bad. Now, anxiety also can be treated with therapy or is often treated with antidepressant medication. So things like Zoloft that we mentioned previously can be used for anxiety. There are also specific anti-anxiety medications. Valium is sort of the classic one of these. Again, anxiety disorder, not something to be ashamed of. I'll be honest, I take medication for anxiety disorder myself. Probably could have used it before I even started using it, but finally talked to my doctor about it basically when I had kids, because it stressed me out even more than other things in the past. And so, again, this is a reality for people. And again, if you feel like your anxiety is starting to obstruct kind of your normal everyday behavior, talk to somebody about that. Maybe it starts with just talking to your parents or a friend or something, but it might be something that you could be helped from a medical perspective as well. Now, there are other disorders that are also considered anxiety disorders, so not generalized anxiety. But these are things that are a little bit more specific and things you've probably heard of before, right? Some people experience panic attacks, which is a really short, intense sort of attack of anxiety. A lot of times people are very afraid or terrified all of a sudden, and they'll experience physical symptoms. So the most common thing is that people think that they're having a heart attack because it might involve chest pain and things like that. Phobias you've heard of, right? Agoraphobia is fear of a place or situation, is probably the most common phobia that we see. But phobias, I want you to keep in mind too, are extreme fears, debilitating fears. So all of us are a little bit afraid of something, right? You might be a little bit afraid of snakes or spiders or whatever. But if you start to change your daily routine because you are convinced that you will interact with a spider or you will interact with a snake, then it might become a phobia, right? If you can't leave your house because you are convinced that the snakes outside are going to get you, that's a phobia versus, I just don't like being around snakes, right? PTSD, or post-traumatic stress disorder, follows some sort of extreme emotional event, right? Some kind of traumatic event. PTSD has been really well documented in veterans, right, who've had wartime experiences. But it doesn't have to be that, right? Maybe you're in a car accident or something like that. Something that you witness can be traumatic and can cause, bouts of anxiety or sort of like panic attacks that stem from, that stressful traumatic experience. And then obsessive compulsive disorder. A lot of people like to talk about, I'm OCD. But we want to be careful with that too. Obsessive compulsive disorder is a very real mental disorder that causes people to excessively fixate on things, leads to repetitive behaviors. Basically, someone with obsessive compulsive disorder becomes convinced that if they perform certain behaviors or if they do certain things, that will be able to stop some sort of dreaded event from occurring, or it'll be able to relieve some sort of discomfort. The old joke, like don't step on a crack or it breaks your mother's back, is kind of like this idea, right? if you're walking down the sidewalk and you're obsessed with not stepping on any of the cracks, because if you step on a crack, someone might get hurt. That's sort of an obsessive idea. And so there was a movie, I put this clip on Schoology too, called As Good as It Gets. The ultimate overall story wasn't really about OCD so much, but this is a movie where Jack Nicholson plays a man who suffers from obsessive compulsive disorder. And so same thing again, not that you need to watch that whole clip, but I think at the beginning of it is sort of the beginning of this movie where they're showing you some of his repetitive behaviors that he does at his apartment. All right, fourth group is personality disorders. This is probably my favorite part. Personality disorders are, as it sounds, like a disorder in personality. And personality is defined psychologically as a pattern of perceiving, relating, and thinking about your environment and yourself, right? So personality is how you act, right? But it's also how you perceive others, right? And it's also how you think about everyone's behavior around you. Now, when we talk about normal personality, right? Normal personality is usually stable and predictable. We all have a certain personality. When you walk into my classroom, after a couple of weeks, I get to know all of you guys, just as you get to know me, and we know personalities, right? You know that, for instance, I'm not real serious all the time, right? Or, for instance, I'm not as strict about rules, maybe, as some other teachers and things. And you can expect that from me, right? That's part of my personality. However, personality is flexible and adaptable, so personalities will change over time. Certainly, a lot of people will grow up, and we call it maturing, but what happens is their personality's changing, right? I was a good student, but I was a prankster in high school and stuff, and I don't think of that much anymore. I still joke around, and I'll still mess with people every once in a while, but personalities change, and as I grew up and I got more responsibilities and whatever, my personality changed. But it is estimated that maybe up to almost 20% of our population actually has a personality disorder. So think about that for a second. Right? Almost 1/5 maybe of our population has a personality disorder. And so we're going to look at, there's a whole bunch of disorders here that this could include. And you might think to yourself, hey, I know somebody like that. Now, again, we want to not be quick to diagnose someone with a mental disorder, but it's possible that some of these might sound like someone you know. Now, genetics might actually play a role in this. A lot of times we think of personality disorders as not being as severe as some of the other mental disorders, and so what they sometimes say is that family history of schizophrenia, mood disorders, anxiety disorders, these things are a little more serious, might be an indicator that someone might be more likely to have a personality disorder if we see that in their family history. Now, treatment is not usually chemical. There are typically not really medicinal treatments for personality disorders. If a personality disorder is bad enough to affect someone clinically, then it really has to do with just therapy to try to help them with that. But again, typically personality disorders, as you might guess, if they really are in this many people in our population, personality disorders often don't really affect someone's life that much, and oftentimes do not even go diagnosed. So I might have a personality disorder, you might have a personality disorder, and we might function just fine, and it might not be something that gets diagnosed. Now, this is a huge group. I'm not even listing all of them here, but I do have most of them in these notes. And we talk about 3 clusters of personality disorders. And so we're going to break them up into the 3 groups here. Now, first we got cluster A. A lot of times cluster A personality disorders are called weird. And obviously that's not a real, politically correct way to approach this, but we call these the weird personalities. And so these people are odd and somewhat eccentric. So you got 3 different personality disorders that we're going to talk about in cluster A. The first is paranoid personality disorder, right? Paranoia. These people are untrusting, right? They will always question the loyalty of others around them, and because they don't trust others, they tend to become isolated, right? When they think of themselves, the way they perceive themselves, they think they are highly rational and logical, right? But other people, if you ask them about this person, they might say that that person is very unemotional, right? They don't show any emotion at all. But the person in question who has this paranoid personality disorder just doesn't trust anyone else, but realizes or thinks that they are extremely rational. The second one, schizoid, right? Schizoid. And so this is not to be confused with schizophrenia here, right? But schizoid personality disorder. Someone who's schizoid tends to be kind of a loner, right? They are emotionally unattached. And this third part is kind of the important part for schizoid. Schizoid personality disorder is someone who does not desire a relationship with others. So it's not that they don't make other relationships. I mean, that's part of it, but they also don't care, right? They are a loner by choice, and they don't want to have relationships with others. And that differs from something else we're going to talk about in a second. The third type of cluster A or weird personality disorder is schizotypal. Again, not to be confused with schizophrenia. The schizotypal person is sort of like the most eccentric. This person is a daydreamer, right? This person talks to themselves a lot. This person might have a really strong belief in things like magic, superpowers. What we say is more than culturally acceptable. So I like these pictures up here. You know, I like Marvel movies and I like Harry Potter, but I don't believe in those things, right? And some people might, right? And if you have a schizotypal personality disorder, you might really obsess over these ideas. Live your life wanting to be a hero. Live your life thinking that there is a place out there like Hogwarts. Now, what happens in someone who's schizotypal is a lot of times they become very uncomfortable socially because they recognize they're a little bit different. And they might dress kind of strangely because they, have different thoughts on kind of what is normal and what is cool. So you might know somebody like this out there. All right, second group. All right, the cluster B personality disorders, or sometimes sticking with W's here, the wild personalities. These people, overly dramatic, emotional, and erratic, right? Now, there's a couple interesting things to point out on this slide. The first is antisocial personality disorder. Antisocial personality disorder is one that often might end up getting diagnosed because these people may get arrested. Right? People who have antisocial personality disorder have a complete disregard for others. Right? They are against society, right? Antisocial. And so often what we see is people break the law, right? And someone who has antisocial personality disorder might actually be very charming and engaging. But kind of on the inside, they really don't care about others, right? They're only doing the things that they're doing, which again are probably unlawful for themselves. And a lot of times someone who's antisocial is going to start showing these symptoms when they're younger. So like it says here, before 15, but you don't diagnose this as kind of a rule of thumb until after age 18, so until someone is an adult. And notice here too that this is nearly impossible to treat. Even with intensive psychotherapy, antisocial personality disorder does not seem to get fixed. As you might guess, we see a large number of people who are imprisoned who have antisocial personality disorder, right? Now, I love to bring this one up here, though, too. We've all probably been guilty of this before, where they're like, "Oh yeah, quit being antisocial," or "Oh yeah, don't mind Eric over there. He's antisocial." You don't really want to say that, right? Because what you really mean is like, don't mind Eric over there. He likes to kill people, because that's what you could be meaning. Antisocial personality disorder is oftentimes tied to something even extreme like homicide. When you mean that somebody just doesn't talk to other people, you mean asocial, not antisocial. So just as a side note. Now, these other ones we can go a little more quickly. Borderline personality disorder is just a really unstable person. Sometimes borderline personality disorder, which is thought to be maybe the most prevalent personality disorder out there, can be kind of confused with bipolar disorder, right? This is where people have rapid mood swings, and these mood swings might be kind of minute to minute, right? These people are usually very impulsive, We might see suicidal behavior in them because of a mood swing that goes really low, and then they impulsively want to do something. They show what's called splitting, which is where you kind of see something in your environment as all good or all bad. There's no middle ground. And these people typically have trouble, forming interpersonal relationships because, not to make light of it, but they sort of are a bad friend because they are unstable, and their mood swings affect their ability to relate to others. The last two have to do with sort of appearance here, right? Histrionic personality disorder is an overconcern or an obsession with appearance, right? These people are all about physical attractiveness. They may attribute things that have nothing to do with physical attractiveness to how someone looks. So, for instance, they might be like, well, I'm sure that she did bad on that test. Look how ugly she is, right? Or I'm sure, oh, this basketball team that we're about to play is going to be terrible. Look how ugly those dudes are. Like, it has nothing to do with that, and that might be a sign of histrionic personality. They might show exaggerated emotion. They might have really low tolerance for frustration and lose their cool with others quickly as well. And then narcissistic, you've probably heard of narcissism before, right? Narcissistic personality disorder is pathological self-absorption. So this might include physical appearance, but doesn't have to. Right? Histrionic definitely includes physical attractiveness as an obsession, but narcissism is all about self-absorption. All right, they don't care about others at all. They lack empathy for others. They will exploit others for self-gain. They will come off as very self-confident, but internally they might not have very good self-confidence. And so that's why I put this picture up here for narcissism. All right, and cluster C are the wimpy people, anxious and fearful personality disorders, and this is our last one. This includes avoidant personality disorder. Now, avoidant personality is someone who really struggles to form social connections because they're so uncomfortable in social situations. But this differs from schizoid that we mentioned before because these patients do really want relationships. Right, so an avoidant personality person, wants to have social interaction with others, but they just struggle with doing that. And so a lot of times people who have avoidant personality disorder end up in alcoholism or drug use because that allows them to relax in a social situation, and so to make the most of it, so to speak. But obviously that's another problem just piling on top. Second thing here is dependent personality disorder, also what it sounds like here. This is where you really want others to take care of you. You want to depend on others. You have sort of a preoccupation with abandonment. You're afraid people are going to leave you, right? And because you're afraid people will leave you, you will be very submissive and passive. So you will, let people do whatever they want to you, walk all over you because you just don't want them to leave your life, so to speak. Dependent personality, you don't make any decisions on your own. You want to rely on others to make decisions for you, and you always need to know what to do. And these people really fear being alone, and unfortunately, a lot of times this leads to people being in abusive relationships. Right? So people with dependent personality disorder are typically not the abuser, right? They are the person who is being abused, and they don't walk away from that relationship because they fear, being alone. And then obsessive compulsive, and realize again, this is not obsessive compulsive disorder. This is obsessive compulsive personality, and this is a perfectionist, right? In fact, I would go so far as to say that being in an advanced class right now, this is probably the personality disorder that you are most likely to have. I'm joking, but certainly this describes me in some cases, right? But that's what obsessive compulsive personality means, is that you become obsessed with particular things, and you are just a perfectionist, right? You tend to not trust others to do things, so you don't delegate work to others because you feel like you need to do it the right way. This is also something people with obsessive compulsive personality can struggle to work in groups or collaborate because they just want to take over. And interestingly enough, this is pretty much the only personality disorder that realizes they have a problem and seeks treatment for it. All the other ones, the people don't usually realize that they are different, but in this case, there's a tendency to see a need for help. All right, number 5 here, we're not going to spend much time on, but that's substance-related disorders. Realize I mentioned my friend Dana working with in addictive psychology. People who have addictions, that is considered a mental disorder. We call these substance-related disorders. Now, I find it interesting, pretty much all Americans have used psychoactive substances before, including you, right? Because psychoactive substances are anything that slightly affect the psychological or cognitive side of your brain. So something like caffeine, right? Or prescription or sometimes non-prescription drugs. Nicotine that people get from smoking cigarettes and alcohol would all be considered psychoactive substances. Now, a much smaller number, and I hope none of you, have also used illicit psychoactive substances, so things that are illegal or not socially acceptable, so things like cocaine or methamphetamines, heroines, that sort of idea. If any psychoactive substance, though, whether it's alcohol, nicotine, or heroin, is used in excess, right, we say that that's a substance use disorder. And what we look for is, is the use of that psychoactive substance negatively affecting someone's health? Substance abuse would mean that they, are excessively using a psychoactive substance too much, but maybe it's just occasional, right? Versus substance dependence, which is usually considered more serious, where someone needs to use these psychoactive substances to feel right or to feel okay. Pretty much all psychoactive substances cause people to develop a tolerance, so you have to keep using more and more to get the same effect, right, from that drug. And then also, most addictions to psychoactive substances lead to withdrawal, which can be both mental and very physical symptoms that come from stopping usage of that psychoactive substance. This is what actually stops a lot of people from stopping smoking, is that they experience nicotine withdrawal, which is miserable, and they go back to smoking again. So if somebody uses a substance daily, if someone realizes that it's affecting their life but they don't stop, these are signs of a substance use disorder. And sometimes too, when you're using a psychoactive substance, you're going to see symptoms from other mental disorders as well. And you probably already knew this, but there is a genetic component to addiction. So, we used to think it was just behavioral, that people's parents were alcoholics, say, or whatever, and so kids kind of took it up too. But they've done experiments, and a third of kids who are adopted and raised by other parents will still form an addiction if their parents had an addiction. So this sort of behavior appears to kind of run in families. Factitious disorders, I just thought I'd bring up because it's kind of interesting, but I wouldn't expect you to know a lot about this. But this is where symptoms are intentionally produced or feigned, right, or faked. People wanting to assume the sick role. So notice it is factitious disorders, not fictitious, but it kind of is like that, right? Fiction, made up. Now, if you're sitting there thinking, like, why would anybody ever want to be sick? It really kind of has to do with this small little bullet point here, right? When someone's sick, and just think about that for a second. I know that you don't want to be sick, but it can be a little bit nice, right? If you're sick and you don't have to go to work, or you don't have to do your schoolwork. I can tell you, I've had like a bad stomach bug before, and that's not fun, right? But for a day or two, I just got to lay in bed, and I didn't have to go to work, and my wife wanted me to stay away from our kids, so they didn't get the stomach bug as well, so I didn't have any of those responsibilities, and I just got to kick back and watch the Avengers movies in order. It's kind of nice, right? And so some people will try to make themselves sick or appear sick to get this release from obligations or responsibilities. The most severe diagnosable form of this is called Munchausen syndrome. This is where you really simulate a disease, and it's usually tied to pathological lying of all kinds. You maybe also have heard of Munchausen's by proxy. It's popular in books and movies. This is where someone is obsessed with needing to take care of someone else, so they make them sick. So if you've ever seen a movie or something before where the evil stepmom is poisoning the stepdaughter so that she has to, depend on her and take care of her. We would say that stepmom has Munchausen's by proxy. Now, Munchausen's and factitious disorders are different than malingering. Malingering is what you might see like in a court case where someone fakes symptoms to try to, for some particular reason, right? So maybe they fake symptoms because they don't want to be drafted in the military years ago, right? Or like I said, you might see it in a court case where the person shows up with their neck brace on after a little fender bender because they're just trying to win money for their quote unquote injury. And then you got hypochondria, or hypochondriasis is the technical term here. This is where you have a constant fear of having diseases, and so somebody who is a hypochondriac always thinks something's wrong with them, right? And so you might know somebody kind of like that too, but probably not diagnosable. In the DSM, technically this is referred to as somatic symptom disorder, or sometimes called illness anxiety disorder, versus calling it hypochondriasis. Dissociative disorder is also interesting, but very rare. So this is where basically someone has a mental disorder where they start to fail to integrate information about really the self as much as anything, right? So identity. Three different things we see here. Dissociative amnesia, right? Means that you can't recall, significant personal information. Dissociative amnesia usually occurs after traumatic injury or a really upsetting psychological event. The book I wrote actually involves amnesia, dissociative amnesia in it. Second option here is called a dissociative fugue. This is where someone has this strange sort of short-lived break in identity. It's usually sudden and unexpected. They might leave home. They might not remember who they really are, right? They're confused about their own identity. They might take on a totally different identity. Once the dissociative fugue passes, they don't remember anything they did during that time. Dissociative fugue, more than anything, is probably triggered by drug use. But thought it was kind of interesting here too. This disorder, while not really diagnosed way back then, was probably the inspiration for Robert Louis Stevenson's old story, Dr. Jekyll and Mr. Hyde, right? And then dissociative identity disorder, or DID, sometimes referred to as multiple personalities, right? This is extremely rare for people to actually do this. You probably have more cases of people trying to fake this in a clinical setting than actually have it. But this is where a person, has, two or more identities or personality states within them that will go back and forth in terms of who's in control of the person. A couple interesting movies about that, though. You might have seen Split. I really like James McAvoy. He's a great actor. And if you saw Split, or what was it called, Glass or something like that, that came after that, he plays a character with dissociative identity disorder. Identity is an older movie, a really good one to look up, though, if you enjoy sort of suspenseful stuff, which has to do with multiple personality disorder, and it's just a really interesting movie. I think I have the DVD now. I'm kind of inspired to watch it myself. But one thing that is oftentimes misportrayed in films is that one identity usually doesn't recognize that there are others. So especially in Split, there's this interplay between the different identities that James McAvoy performs, and there really wouldn't be that in someone who truly has DID. This is actually one way that doctors can kind of see through someone trying to fake it. If someone starts to act like, they are aware of the other personalities, that's usually a sign that it's not real and that the person's kind of making it up. And then the last thing we have are cognitive disorders, which are delirium and dementia. This is sort of a disturbance of consciousness, is what we call it, right? People can't quite keep attention. They might struggle with memory because of this. They are kind of in and out of awareness of their surroundings. And delirium is a little less common, right? This is usually acute, so it comes on just out of nowhere. and it kind of fluctuates over a few hours and then passes, or it can last up to weeks. But delirium usually has an organic etiology or an organic cause, right? So this is kind of this situation that we mentioned way back at the beginning. A lot of times there might be some kind of underlying condition. Maybe a brain tumor is causing delirium. Maybe an infection is causing a delirium. A really high fever can actually cause delirium. Maybe somebody has a nutritional deficiency, which can cause delirium. Certainly, intoxication with alcohol or drugs can cause delirium. And there's a specific kind called delirium tremens, which is associated with withdrawal from addictive substances that people can suffer from. Now, more common and more kind of pertinent for us is dementia. Right? Now, dementia is a lot like delirium, right? But they call it a global loss of cognitive and intellectual abilities, which means, kind of an overall reduction in someone's thinking power, right? Their cognitive abilities. It affects memory, it can affect language. As we mentioned earlier in the testing idea, they don't think abstractly anymore. They might have impaired judgment. They might have altered personality. And, dementia is common in the elderly, right? 5 times as common in those over 80 years of age. I mentioned that if someone's over 65, you usually want to do a cognitive test during a physical. So 65 is about the time we maybe start to see some onset of dementia. That would still be considered pretty early onset at that point, but it could happen. And usually in dementia, whereas delirium has a sudden onset, dementia is a gradual onset, right? And it goes on for months or years. So you might have a grandparent or great-grandparents who is 75 and they're starting to show some signs of dementia. And then, a few years from now, it's grown worse, right? The most common things that we see, there's generalized dementia as well, but there's Alzheimer's type dementia, which is called primary degenerative dementia or Alzheimer's disease. And there's vascular dementia, which comes from strokes, or like mini strokes. I can tell you in my family, my great aunt, so my grandfather's sister, suffered from Alzheimer's disease. Hers was interesting where she just sort of started to change personality a lot, and what we started to see was this impaired judgment and inhibition. She was a very energetic lady, but she was also extremely proper, very religious, and out of nowhere, all of a sudden, we were at this family birthday party, and she starts cussing like a sailor. And so it was one of the clear signs that something was going on with her, and it was kind of the start of some Alzheimer's changes, in which case, someone with Alzheimer's loses memory and really eventually starts to lose the ability to even communicate with others. Vascular dementia, again, really common from stroke. We think that my grandmother actually started to suffer from this late in her life. My grandmother had a couple of what are called transient ischemic attacks, or kind of like mini strokes. And after that, she started to have more and more trouble with remembering things and whatever. And so, that was probably, triggered by the stroke, led to these dementia-type problems. But again, way common in old people. Not going to see this sort of thing in young people usually. Now, the last thing I'll just point out, and this cracks me up when I saw this picture on the internet. Most of the time we're just guessing, surprise. But full mental status examination is in-depth and can be lengthy, and I won't expect you guys to be able to do that. But with the juniors, we are going to look at mini mental status exams just a little bit. And usually these mini mental status exams only take a couple of minutes to perform. And they also are usually little assessments that they might be designed to look for particular conditions. So you see this little paper here that I've got, or this form on here. And this would be a mini mental status exam that you could run through with a patient. Orientation, we mentioned, what's the year? What's the season? What's the date today? Where are we? Right? Those kind of questions. Things like, again, can you count? Can you spell forward and backward? Again, you might ask them to remember 3 objects and then come back to that a little bit later and see if they remember them. You might show them an object, like hold up a pencil and ask them what it is and see if they can tell you what that is. Have them repeat things that you ask them to say. Have them do things and follow commands. Might have them copy a picture, that sort of idea. And so we're going to play around with this, actually have you guys try these on some people at a later date. And just to close up, the one that we're going to use is actually one that's designed more for an Alzheimer's or dementia test. So if any of you would be able to go out and perform this mini mental status exam on maybe a grandparent or something, you might actually see some interesting scores come from it. Otherwise, people tend to score just fine. And so in the past, we've actually done this in our school building. It scares some of the teachers, but everybody always does fine on it. The one exception, one time we had a staff member who was getting over a concussion, actually, and she actually had a little bit of trouble with this. And so that obviously wasn't because she had dementia. It had to do with the concussion, but kind of interesting. So we'll talk about that more later. So I know this was lengthy. I hope you found it a little bit interesting, though. I will see you guys hopefully sometime soon. So keep working hard.